Good morning. It's great to see such a good group of people. I figured anybody who came to this session on a Wednesday was dedicated to maternal and newborn health. So I'm really, really glad to see all of you here. And we're going to try and make this a little bit interactive. I think from my perspective, having been here since Monday, we may all be to the point of death by panel, right? So we're going to try and get some input from all of you. So if you're sitting way in the back and you want to come forward, that would be great. But if you could at least make sure that you're sitting next to people that you don't know, because I'm going to ask you to speak to the folks that are in your row. So make sure that you're not sitting in isolation and that you've got somebody that you don't know nearby, so that we can promote a little bit of interaction. And so I jumped in without even introducing myself. I'm Martha Newsome with World Vision International. I'm also on the board of the mHealth Alliance. So World Vision is very involved in maternal and newborn health as well as mobile health. So I'll share a little bit about that. I've got a great panel with us. We're still hoping that one lost panel member may appear. So if there's a little bit of hustle and bustle up here, you'll know why, because we have one missing in action. So we hope that he appears. But just to get us started, I thought I would just give a little bit of an overview of how, just looking at the continuum of care, all the interactions of the health service system, the community system, and then where does mobile health intersect with that, and what are the opportunities. And then we'll have our panelists speak more to their experience and the lessons learned that they have in maternal newborn health and mobile health, and then what is the future going forward for all of us. So we'll see if this technology works here. Even though I love technology, I'm not the best user of technology. So I thought I would just share a theory of change that World Vision has developed around our work with community health workers, frontline health workers, with a model that we call timed and targeted counseling. And timed and targeted counseling is really equipping the community health worker to interact with the pregnant mother and mothers of under 2 children with messages that are appropriate, that are timed and targeted to something that she could action immediately and be able to then agree to try out until the health worker comes back and checks in with her. And starting at the top, really what we're about and talking about in this session is how can mobile health really help us to achieve MDGs 4 and 5. So Millennium Development Goal 4 around child mortality and 5 around maternal mortality. So down at the bottom then you have all of those foundational project sort of activities within mobile health that are necessary to get a mobile health program started. From there, then, you look at the deployments and what are the deployment actions that are needed in terms of project management, in terms of the system, support system, the training, the monitoring and evaluation. And sometimes we focus on any one of these levels and forget about the other levels that are needed to make the whole mobile health system work to achieve the outcomes that we want to see. Then from there, we would be looking at what are the outputs and the immediate outcomes that we'd like to see, and then the long-term outcomes that then gets us back to the impact level of achieving MDGs 4 and 5. So in terms of mobile health solutions, we can look at solutions that look at behavior change. And so Daphne is going to be looking at that with the mama work and the baby center work that she's going to be speaking about. And then also we can be looking at the health system strengthening side. And so we'll have examples with Paula from Latin America, looking at some of the examples there and what's been done in Latin America. And then Mark also looking at how mobile health has helped to improve women getting to facilities to have skilled birth attendants assist them. So really addressing maternal mortality. So all of that is what builds up then to the last level in terms of improved maternal health and birth outcomes. And so that's why we're all in this room. Again, using the continuum of care, Jennifer Potts from the mHealth Alliance gave me this slide at the Cape Town Summit, not the last Cape Town Summit, but the previous one. And really this just shows all of the points in the continuum of care, both at the facility level as well as at the community level, where mobile health solutions can be brought in to address any of those points of care along that continuum from pre-pregnancy to delivery, and then the postpartum, postnatal period. And so then you have applications that can look at health information, patient management, improving the quality of the health system, the data collection side, the reporting side, and then the analysis. So you can think about this continuum as the panelists are talking and where their presentation fits into this broader continuum. For World Vision, we've been working in a number of countries in Afghanistan and Zambia and Mozambique, and then we have about another 5 or 6 countries that are coming on board, looking at sort of the functional areas of mHealth solutions. So you can see the functionality piece there on the right side, sort of all the different options, and we've been working on the first 4 of those. But then how it fits into health system strengthening, and how we want to certainly build country ownership. There's been a lot of discussion about that, making linkages to health systems and services. And then the community level, I think there's been less discussion about how does mobile health help build the community mobilization and sensitization, and then the whole support system around the community health workers in terms of registration, training, supervision, incentives, performance evaluation, and registering those CHWs as well as their clients or beneficiaries. And then at the household level, how do we really get down to the behavior change piece with improved care, improved referrals, counseling and behavior change communication, getting them to urgent care, getting moms and newborns and children to urgent care, and then the monitoring and evaluation, improving the use of data in the health system, the provision of commodities, and then the diagnostics. So those just giving you kind of the broader, the universe of mobile health solutions that can be used for maternal and newborn care. And then I think those of you who have been with us, we've been talking about some of the critical issues in other sessions, so we probably won't be talking about these as much. But first of all, how do we build partnerships across the ecosystem in each country so that we understand what the government needs and they are able to decide what system they want to use? Is a broker needed to bring all parts of the ecosystem together? Then can we speak the same language? I think those of us who have been on this journey, if we're coming from the public health side, we speak one language. If we're coming from the IT side, we speak another. And then being able to translate that terminology and be able to communicate together and partner together. And then from the aspect of this session, how do we build systems that are really user-driven, that are really responsive to the needs of the mothers, the needs of their families and their children, and then the community health workers in particular, or the health staff. What's the business model? There's other sessions on this. So here we really want to look at the impact. So what has been the impact, and then how can we take that forward collectively to get back to achieving MDGs 4 and 5? So thanks. It's great to have a full house. I'm going to quickly introduce the panelists so that they can come up one by one, and then we're going to have some fun discussion, I hope, at the end, and we'll try and keep you all awake. So Paula is going to be leading off and sharing her experience from Latin America. She is a faculty. Paula Otero is a pediatrician. She's a faculty member at within the Department of Pediatrics and Health Informatics at Hospital Italiano in Buenos Aires, Argentina. Just hearing from her how beautiful Argentina is, so we'll go there in our minds. And so we'll hear from her first, and then we'll move on to hear from Daphne Metland, if I can get my notes here. She is the editorial director international of Baby Center, and she's really been responsible for developing all of the content of the MAMA project. So she brings extensive experience from working with 29 million mothers around the world with Baby Center, and then translating that into the messages that have been integrated into MAMA, and she'll tell you more about MAMA if you don't know what that is. And then Mark Mitchell joins us also as a pediatrician. He's the founder and president of D3 International, which was founded in 2004. He has worked in over 40 countries in, I think, all parts of the world, and is a lecturer at the Harvard School of Public Health. And so he will be sharing his particular expertise and experience in maternal, newborn, and child health. And we do hopefully have one more panelist. Maybe I'll introduce them in case they appear, the one that has gone missing in action. We were hoping to have Shashir Dahal join us. He's a senior medical officer from the Ministry of Health and Population in Nepal, and he was going to be sharing his particular experience of working with the ministry from Nepal, and we're hoping that he can join us. I'm not quite sure what has led to his delay, and we'll see if he comes to join us. So turning over then to Paula, and we'll see if we can, our folks in the back will be helping.
Well, good morning, everyone. Thank you for being here on the last day. I hope we are able to share with you some of our experience and the ideas on how mobile health can help maternal and newborns. Especially, I'm going to speak about the current situation in Latin America. As you all know, maternal mortality is a great burden. Almost 800 women die daily of preventable causes related to pregnancy and childbirth. This was addressed early this morning on the plenary session with Ariel Palacios and some other speakers. Unfortunately, most of the nearly 100 of these deaths occur in developing countries and developing economies. Latin America is almost, most of the countries are included in this number. And although it might sound like we all know it, maternal mortality is high in women living in rural areas and poor communities, and that is the current situation in many areas of Latin America. And young adolescents, that would be one of the greatest population groups we have to address, are the ones that face higher risk of having complications during pregnancy. Nearly the maternal mortality ratio is 15 times higher in developing economies than in developed economies. What happens with Latin America? Latin America is quite a different continent or region compared to other regions of the world, because we have, for example, countries that, such as Brazil, Argentina, and Chile, that are included in the G20, Mexico, that are included in the G20 group, other countries, and we could say that they are developed economies, although I live in Argentina, and I know I don't live in a developed economy. And there are other countries also that belong to the OECD. So we have this kind of disparities between high-income countries that are shown or seen by the rest of the world, but really inside the country, the current situation is very similar to the ones you would see in not developed economies. So 15,000 women die every year in Latin America due to causes related to pregnancy, and as Martha spoke earlier, mainly the MGG5, it's high compared to developed countries. So you can see it's nearly 130 maternal deaths per 100,000 live births. If we see some numbers, this is what I was trying to address before. Most of the numbers that include different indicators as lifetime risk of maternal death, women receiving prenatal care, birth attended by skilled health staff. If you see the numbers of the region as a whole, they're quite similar to those of OECD countries and not so similar to the ones in Africa. That is the thing about statistics, that they might show like an average number, but the situation is small in small communities in those countries that do not reach that level in Latin America are very similar to those in Africa. So one of the topics I want to address today is, although numbers may look like Latin America is a prosperous region, there are some areas that still behave like sub-Saharan Africa. So we have seen throughout the full conference, for me it's the first time being here, and I learned a lot of things from the mHealth Alliance and the mHealth Summit. It's definitely a useful tool that we have to improve access to health in areas where there's low offering of healthcare workforce, especially nurses, OBGYNs, and special people trained in taking care of pregnancy and newborns, where there's limited financial resources and there's a high burden of disease. In this case, it would be a high burden of preventable causes. That is a crime that we do not address that. SMS can affect behavioral change that has been described, and this is in this current paper. You can see the reference below. They can change by in an efficient, low cost, and the way of disseminating through a regular phone or a smartphone information in hard-to-reach populations. This can also help to empower both patients and practitioners that don't have access to a big healthcare facility where things can be treated, because mainly of these actions could be taken at the home and not necessarily to be taken at a healthcare facility. There are also other programs or areas that we could address regarding what is the use of mobile health, especially when we speak about from the health worker-centric point of view or from the patient-centric point of view. So they would be integrated. And I found that this picture is quite easy to understand all the different areas that we can work on preventing complications for the newborn and for their mother. There's also several systematic reviews of mHealth that have shown that this is quite successful, especially in reminders and to improve immunization. Regardless, when we speak about maternal health, there are many topics that could be addressed, but mainly the programs that I have reviewed so far, they mainly with reminders for the mothers for their pregnancy controls and immunization rates, and healthcare counseling for preventive practices are the ones that were really showed a difference in the outcomes in this kind of population. What happens with mHealth in Latin America? Well, most of the research that has been done is not on Latin America, and they have done, of course, in developed countries. So there's a lot of experience, and I have seen throughout the conference that in the US, in Europe, there are many studies going on about the how mHealth can help maybe in chronic conditions that also affect not only developed economies but also developing economies. There's have different campaigns that have been evaluated, like health campaigns or small case studies, and most of these programs are financed by humanitarian programs, organizations, or private foundations. The thing is that these programs are not fully integrated with health systems at all the levels of care. So one of the challenges that this mHealth situation is to address is how to integrate it with a health information system, with electronic health system that might be within an institution where the patient would later take care. The mHealth for Latin America hasn't arrived yet, mainly because what I said earlier, that the situation in some of the countries would seem as a developed economy, and like all the different programs that are going on mainly address sub-Saharan Africa, but I'm trying to call for the action that Latin America needs these mobile health applications, and I hope that in the near future, some programs would also include Latin America as part of their pilot projects. So maybe there's a lack of coordination between coordination and collaboration of all the stakeholders involved in mHealth that still hasn't got the call for Latin America. PAHO, the Pan American Health Organization, has proposed an e-health strategy and plan of action for the next 5 years, and this is the first time that, regardless of e-health, mHealth has been as one of the main topics that PAHO is working, and all the countries that are member of PAHO have fully addressed this. So, especially regarding mHealth, the definition of the e-health strategy states that it's a medical and public health practice supported by mobile devices, such as mobile phones, patient monitoring devices, and other wireless devices. All this also needs to be integrated, as I said earlier, with electronic med records. They also address telehealth, e-learning, continuing education, and standardization on interoperability. Currently, there's a project going on with PAHO that is called e-conversations, where they're trying to gather people from the region in order to propose how the agenda should be regarding all these topics. These conversations are going on online, and you can see more on the PAHO website. If I go especially to what has been going on currently in Latin America, the Center for Latin America, the Latin American Center for Perinatal Care, that also belongs to PAHO, has developed they have this perinatal information system that was on paper, later was available online, and right now is available on handheld devices. This system has been used for a long time. It's mainly oriented to healthcare workers, but usually It used for gathering statistics about how the information regarding the pregnancy, the pregnancy outcome, and the newborn is established. A simple form to communicate and to handle statistics mainly for this area. One project that has been successful, especially in Peru, is the Wawa Red. Wawa means baby in Quechua. Quechua is the local language in Peru. It's a project coordinated by the University, Peruvian University Cayetano Heredia, and mainly provides access to pregnant women in order to get an interactive system of warnings of complications, reminders of appointments, and motivational messages. Now this Wawa Red project has evolved, and now they're trying to integrate it with electronic health record where all these pregnant women seek for care. So you can see there are not too many projects going on, although PAHO is starting to build a health strategy. Not many projects related to maternal and newborn care in Latin America have been developed so far. But I guess that with all the experience that was shown out through the conference, I hope that Latin America would get on the train and not lose it. Thank you.
Great. I don't know if the mic's on.
Good morning, everyone. Ooh, right. Can you hear me? Excellent. Right. And it's the green to go. Yeah? Fine. Just make sure the technology is working. The focus has been for some time now very much on the medium. It's all about remote monitoring. It's about phones. It's about apps. It's about data collection. And actually, what most people need is information. And mHealth is brilliant for that. So I'd like you to come with me as we drill down and look at the messages and what you need to do with your messages to make them work. Someone said earlier this week that mobiles don't deliver babies. I'm sure someone's working on an app for it somewhere. They don't deliver babies, mothers do. And what's this new mother doing? This is the symbol of mama, this image. And I think it's perfect because she's reading a message. And it's a message that could save her life or her baby's life. It's a message that may say, keep your baby warm. Or maybe it says, keep the cord clean. Or maybe it says, give your baby your breast milk, your colostrum, it's really important. Or it might say, if you're bleeding heavily, go back to the clinic. Those things can save a mother's life and a baby's life. That's the power of messages on mobile. Now that we have, or we're getting to the point where there are phones in every mama's hand, which is one of the things that mama has been set up to get messages on those phones, we want to make sure that the quality of the messages that go on the phones are very effective. And to do that, phones are brilliant because they're immediate. They're direct. There's no last mile to worry about. They're personal. They give the woman the right message at the right time. We're not telling this new mother here in that picture that in 6 weeks' time her baby should have an immunization. She'll forget that. At the moment we're saying, put the baby to the breast, hold the baby skin to skin to keep him warm. These are the things she needs to know now, today. And it's not just about pregnancy, although that's what mama is looking at. This idea of stage-based information works for other conditions. For instance, circumcision. You know the procedure date for the man, and you can send messages every day afterwards to help them identify if they need to go back to the clinic. You know when someone's been diagnosed HIV positive, and you know that they'll be going through an awful lot of emotional traumas and worries in the few days and weeks afterwards. You could tailor your messages to help people get through that stage. So it's not just about maternal, although that's my particular passion. So 3 words for messages: immediate, direct, personal. That sums up the power of mobile messaging. So how do you make those messages that are exactly right for each user? If anyone remembers the early days of the internet, there was a term that was bandied around called mass customization. And that's what we all do all the time on the internet. We chop up our information and give it to people at the right time. And that's what we do with Baby Centre. Baby Centre's in 20 countries around the world. It's got over 25 million unique visitors every month. And anybody who's a Baby Centre member gets a weekly email with a message or messages on it. And every day at Baby Centre, we get emails from people saying, "How did you know my baby cut his tooth today? Do you have a video in my living room?" Or one I read recently, coincidentally, was a woman saying, "Do you know, I woke up this morning and I wasn't feeling sick anymore, and I thought there was something wrong. And then I opened my email and it said, not feeling sick anymore? That's fine." So if the Duchess of Cambridge is reading her Baby Centre emails, she knows soon she'll feel a bit better. So in terms of your messages, the messages in the red area will be spot on for people. You will be talking to them just as they are doing that thing. The people in the green area on this chart, you'll be a little bit out. You know, maybe that woman's baby doesn't get its tooth until next week. And the blue area will be a bit further out. Maybe that woman's baby got her first tooth last week. But the secret is those blue outliers will be different every week. So you just have to please most of the people most of the time, and they think you're a magician. They really think you are walking this journey with them as an individual. And occasionally we get emails from people saying, "You've helped me through everything. Could you help me choose the colour for my nursery, please?" The challenge for mobile, in an email you've got lots of words. In mobile, you've got 140 characters, including spaces. Now, we write 140 characters for Mama because the local NGOs who take the messages and adapt them for use locally usually like to add a greeting or a sign-off, so we give them a bit of leeway there. But 140 characters, including spaces. And if you're doing audio, about a minute is the maximum. When we launched an urban program in Delhi, we started with 2 minutes, and we found that mothers struggled to remember everything in 2 minutes. It's much more effective to do 1 minute and keep it completely focused. So, of course, that means every word has to count. I just want to show you what we did with the new PMTCT messages that we've just launched as part of the Mama program. And let me explain the geography of this slide to begin with. This is what the messages look like when the NGO downloads them. This is just one. There's about 100 messages for pregnancy and 150 for baby. And if you look at the first column, the number 9 is the 9th month of pregnancy. 38 is the 38th week of pregnancy. If you skip to the very last column, those are notes for the NGO. We explain what we're doing with that message and how they should look at adapting them. The horizontal bar at the bottom are all the references for the messages. So every single message in the Mama program is fully referenced. The PMTCT messages actually come in 2 message streams. The first one is for cultures where there's a high incidence of HIV. And the second one is when you're sending messages to women you already know are HIV positive. They've signed up and told you that they're positive. And the wording on those 2 is slightly different. Because when you are HIV positive, you don't need a message that really tells you that every time, that starts with "because you're HIV positive." So we fine-tune the wording so that for the general audience we are raising awareness of HIV. For the woman who is HIV positive, we're giving her support and help and information. And those subtle differences are really, really important. And I've been an editor for more years than I care to remember. And I guarantee that that second column will work with a woman who's HIV positive. Oh, where's my... Right. Some of you may know about the law of the minimum. It was originally developed for agriculture. And it says growth is controlled not by the total amount of resources available, but by your scarcest resource. So in agriculture, if you've got plenty of land but no seed, you're not going to get much crop. If you've got plenty of seed and no fertilizer, it's going to limit your crop. If you've got a wonderful crop and no one to pick it, it's going to limit your harvest. So that's the law of the minimum. So I'd like to ask, what is our scarcest resource in mHealth? Lots of people would say it's money. Having seen the slide on 140 characters, you might say it's the 140 characters. But I would suggest it's trust. That's your scarcest resource. Lots of people will have read many of the myths that are going around. I just found a few from various sources. One of the myths in Africa at the moment is, you know, white people are giving us white bed nets to put up in our houses. Maybe it's so they can spy on us. In Pakistan, there's a rumor that having your baby immunized will make them infertile. In Ghana, there was a rumor going around that if you had your baby at a clinic, it was because you'd been unfaithful to your husband and you didn't want the family there. So everyone you send a message to has to trust you, or they won't act on your messages. You need to make those messages regular, personal, relevant, supportive, and easy for them to act on. So they go and do something that you suggested in the message, and it works. And they come back and think, wow, that worked. And then they'll go on using your messages more and more. So I'd like to propose a new mHealth law of the minimum. Your mHealth project will be limited not by how much you spend or how fancy your technology is, but by how good your messages are. And I know we've done a lot of work on the medium over the last few years. I think going forwards, we really do need to look at our messages. And we need to look at how we measure things. At the moment, we're all so delighted we're reaching 20 million women, or 5 million, or 500. We're thinking about numbers. Actually, I think in a few years' time, or even next year, we should be here saying to each other, today I sent a message to a mother which enabled her to save her baby's life. Because that's what the message is all about. Thank you for your time.
Thank you very much. I'm Mark Mitchell. I'm president of DTRI and lecturer at Harvard School of Public Health. When I started on my mHealth journey about 10, 12 years ago, there wasn't an mHealth summit and there wasn't mHealth. And people thought I was crazy. There's no way you can do what it is you want to do, and no one's going to have phones, and I mean, skepticism was huge. It's a treat to be here now when people don't question whether these things are possible, and now the question is, does it work? And what I'm going to present to you is some, I guess, first evidence that it's possible, and second, that it works. So this particular project that I'm going to describe to you is in Zanzibar. It's 2 islands off the coast of Tanzania. It's part of Tanzania. And the question is, can we get women to deliver in a facility? I don't think I need to convince you that facility-based deliveries are safer. In Tanzania and in Zanzibar, about 50% of women deliver at home, even though almost all women get antenatal care. So the challenge for us was, how do we get women to deliver in facilities? I'm not going to go through a whole lecture on the 3 delays. Many of you will know about that. But that's what we were trying to overcome. So the decision to seek care, to get to a facility, and then once you get to a facility, to make sure that the right things happen. What we do generally at Dietrich is three things. We develop clinical protocols or algorithms that enable better quality. And we program them. We develop software so that it can run on a phone and be easy to use. And that combined is decision support, hence the D of Dietrich. And we create an electronic patient record that both helps the person that's providing care and also provides us the ability to transfer records, to aggregate data, and so forth. So I like to start at basics, and the basics here is, what does a phone do? So how many of you have cell phones? How many of you have smartphones? So do you have smartphones because they make better phone calls? No, they actually don't make better phone calls. You have smartphones because it does other things. It runs applications, you can store data, you can use GPS, well, unless you have an iPhone, which doesn't do that so well, but. So it's all these other things that make the cell phone, you know, the thing that everyone has in their pocket or in their hand. So we're trying to take advantage of those capabilities in order to get mothers the kind of information they need to deliver in facilities and to facilitate transportation. So we combine 5 things on the phone. We put the phone in the hands of traditional birth attendants. The traditional birth attendants make their money by delivering women, children at home, and I'll get to that in a second. But we wanted to give them a different set of tasks. So the protocols help them to identify women who have danger signs, who are in trouble, who have some kind of problem that would mean they absolutely have to deliver in a facility. But in addition, it also provides counseling so that with the women they can do birth planning. And because embedded in the counseling are messages about delivering at a facility and why it's better, this helped to have a different kind of communication between the traditional birth attendant and the mother. The second was mobile banking, because someone had to pay for the women going to the health facility when she's in labor. I don't think it's very reasonable to expect a woman in labor to take a public bus to the hospital when she's about to deliver. It doesn't seem like that's going to work very well. So we also had cell phone numbers of vehicles in the area, private vehicles, not necessarily taxis, where the driver agreed for a price that was negotiated in advance to take the woman to the health facility. We had pre-recorded permissions for transfer from husband, mother-in-law, whoever it was, recorded during the pregnancy so that at the point of transfer you weren't running around looking for the husband. And finally, a phone call to the facility to make sure that the doctor was in today, the nurses were there, they had IV fluids, whatever it was you needed, so that when somebody got to the hospital, they actually got care. This enabled us to screen the mothers and, as I said, do birth planning, to arrange transportation, and we added another thing, which was follow-up. We know that it's very important that women after delivery have somebody follow up for both them and their baby. We were convincing the TBAs to accompany the mother to the health facility, and so they weren't anymore delivering the patient. We reimbursed them for the amount of lost income because otherwise they weren't going to make the referral. This is their job, and if you take away their income, they're just not going to participate. It was about $6 per delivery. For that $6, they accompanied the women. They managed the mobile banking. They stayed with the woman as an advocate at the health facility, and then they followed up the mother and the child within 48 hours after. Does it work? Yeah. So this shows a baseline, which is the DHS data, and the first 6 months, this was part of a Bill and Melinda Gates Grand Challenge grant. So we only had 6 months of data collection, and during that time, we went from a baseline of 33.6%, according to DHS, to over 67% of women delivering in a facility. Pretty spectacular difference. We were a little concerned that was going to fall off. In fact, over the subsequent 6 months, it went up, and so we're now at about 71% facility-based deliveries. Because I'm a pediatrician by training, and I like to focus not just on the numbers, but on the stories. I want to share a couple of stories. This was a woman who gave birth to twins. She didn't know she was having twins. No one else did either. And might well have gotten into trouble had she delivered at home. In fact, she went to a facility and it had a happy ending. Second woman is an interesting story. She was set to go to the hospital, but had a quick delivery, and so wound up delivering at home. The delivery went well, but the next day spiked a fever. Because of the program in place, she contacted the TBA. The TBA referred her to the health facility, had the whole transportation mechanism in place. She was treated for sepsis, and she and the baby did well. So, you know, it's not just getting the women to, it's not just getting the advice, but that's critical. It's not just getting them to the facility, but it's making them part of the system so that the health system now is in fact connected to the women who are delivering. What we're trying to do is to provide a continuum of care, and as I mentioned, we use the medical record to link the clinic staff and the TBA. In this case, it was with a phone call, but in other projects that we're doing, we actually transfer the record from facility to community health worker and back again in order that there is a continuum of care as the woman goes from a variety of providers across time, so tracking things like weights, immunizations, antenatal through the pregnancy and so forth, so that the medical record that we create is fed back into the protocols in order that the provider seeing the woman or child or whomever it is knows what went on the last visit, the one before, and then can interpret this data in order to provide better care. And across generations. So, for example, linking maternal and child record for PMTCT, where the child born to an HIV-positive mother needs special care, and in order for that to happen, some mechanism needs to be in place that you can link the records of the mother with the records of the child and control who has access to that kind of information. We are working to develop protocols pretty much for everything. What I say is we would like protocols for 95% of all patient visits. We'd love 100%, but hey, I'm modest. And, you know, so it's not just maternal care, it's not just child care, it's everything. We believe that critical to the success of mHealth in the hand of health workers is that they have one phone and many patients with many problems rather than many phones, one for each problem. There is no way you can justify the cost of multiple phones, each doing its own project, each funded by its own donor. You need to integrate across all of those things. And of course, we can't do it alone. We have many, many partners. We don't deliver health care. In the example that I presented, that's government health workers. Generally, we work in government clinics, but not always. And we have lots of partners, funding partners, government partners. This happens to have the United Republic of Tanzania, but we work in a number of countries as well, and partners who are implementing partners. And we're happy and proud to be doing that. So that's what I wanted to say, and I wanted to end by saying it's exciting to be past the question of can we do this, and I also believe that we are starting to accumulate evidence to show that it's worth doing, it's worth the investment, and I want to encourage all of you who are doing this kind of work to collect that sort of evidence, to make sure that the projects that you're doing has a component that really looks at, does this work? Because that's the kind of evidence that we need to convince others that it's worth doing. Thank you very much.
Great. Thank you, Paula and Daphne and Mark. Those were excellent presentations. I see people getting up and running for the room, but if you do have to leave, we understand. But I hope now this could get us into some of the nitty-gritty and really involve all of you. First of all, I'd like to understand how many of you are involved in a mobile health project that addresses maternal and newborn health. Can you raise your hands? Wow. Okay. So that's very exciting. So now the next thing I want you to do is then make sure you're sitting close to somebody that you don't know. And I want you to get into a group of 2 to 3 people, just small buzz groups. Introduce yourselves quickly. Say what you're doing with mobile health. And then if you could talk about what is the critical challenge to getting the types of programs that we heard about from Paula, Daphne, and Mark to scale in countries where you're working. What would you, as 2 to 3 people together, what's holding us back? And if you could decide if there's something really riveting that you agree on, then you can jump up and get to the microphone. But we want you to agree what is the most significant challenge that is keeping us from using mobile health to address MDGs 4 and 5. So you have about 5 minutes to do that, and we'll have a little buzz group up here, and then I'll come back and see what do you think is the most critical challenge in your buzz groups. Oh, great. It was wonderful to hear the buzz in the room. I know that the difficulty in letting you talk is that nobody wants to stop. But there's no one at the microphones, so who has a critical challenge? Woo! I need a whistle. Who can whistle?
Yep.
I know if you start people talking, then it's impossible to stop. But we'll come back. You'll have another chance to talk. So just hold where you are in the conversation. We'll hear a couple critical challenges, and then I have another question for you. Does anybody feel like they have this, they've landed on the challenge, capital THE, that they want to share with the rest of the group? Nobody's at the mic. Does that mean that there's nothing so big that we all need to talk about it? Great. Introduce yourself and tell us.
Hi, I'm Amanda McCulloch, and I work as a monitoring and evaluation advisor at John Snow Incorporated. And I don't know if it's the capital T challenge, but the one that we really hit on was the challenge with human resources. And that is, you put a project or a pilot project in place, and you train a number of people on how to use a certain kind of technology. You might want to go the next step and do training of trainer type models and keep scaling up that way, but you have a lot of turnover and a lot of health staff and movement in between agencies and spaces. And so maintaining and having the necessary folks in place who can go ahead and support the scale up of mHealth technologies would be a big challenge. And then financing.
Great. Okay. So the human capacity and the skills, and then the finances. In the back, please.
My name is Nalois Olivia from Health Child in Uganda. I've attended so many sessions during the summit, but what everyone is doing is making messages for mothers. But in Uganda, the challenge that we have is most of the mobile phones are owned by the men. So as Health Child, what we do is you just have to develop tailor-made messages that target the men so that they can reach the mothers. And maybe from baby center and mama, that is one of the things that we need to look at, because in developing countries, it's the men who own the mobile phones, not the women. Thank you.
Great. So male involvement, excellent, excellent point. To the front, we'll just take these ones so no one else stand up, because we're going to have another question that we're going to discuss. So the floor is closed now on the challenges. We'll take this gentleman in the front, please.
Okay, I'm Dr. Ongala. I work with Africa in South Africa. We're actually using PIT track. We are tracking mothers who come in ANC. You register them, track you through your scheduled visits, through pregnancy, delivery, and then you come back with the mother after delivery, with the child after delivery, and do PCR. So the purpose is that we get zero transmission rate, and it has worked in the site where we are implementing it. The control site has about 30% transmission.
Great.
The challenges are that, first of all, We have to get a developer to get us this system. And he charges us about 50,000 rands. That's basically about $8,000 every year to maintain it. And it's PC-based, so where there's no power, you have a limit where you can reach. And if the computer gets spoiled, there's a rural area, there's no skills actually to then fix your computer. So you run for years or even months without. The last one is basically that though it's a very simple system to use, you really get into trouble when there's no buy-in from the nurses. It is nursing, it is nurse-based basically. You don't get the nurse to buy it in. You really don't get the services going on.
Great, thank you. I think you've rolled in a whole bunch of challenges there. We're going to hold for just a second. I want to hear from either Paula or Daphne with what do they think as the key challenges. Can you comment, maybe both of you, in fact?
Thank you. Well, what I think is I completely agree with all the challenges that you have described so far. But as speaking from the Latin American region, I believe that one of the challenges is don't forget about Latin America. Most of the projects are, I'm trying to say, that is the message I'm trying to get. One of the challenges that I believe that most of the programs are forgetting about Latin America.
Okay, the call for Latin America. And then Daphne, what is the key challenge from your perspective?
Well, perhaps I could just talk about the men, first of all, because Livia, you'll be pleased to know we're writing messages for guardians as we speak, and we'll have those ready early next year. So there's a whole new message program coming aimed at guardians, and that'll cover husbands, village elders, mother-in-laws, all sorts of people who influence. And then in terms of a key challenge, what I'm seeing is a lot of brilliant things happening in lots of different fields. Lots and lots of you all doing wonderful things, and it's a bit like medicine was in medieval times. There were 20 different theories about how the body worked, and it wasn't till there was a huge paradigm shift, and I think it was Harvey and the circulation of blood actually pulled all the theories together, and then suddenly people could say, oh, that's what the landscape looks like. We've all agreed it, and now we can go forward. And I think we're coming up to a paradigm shift on mHealth, where we've all agreed the systems, the processes, that we know it works, that we know the costs are, and now we can take off.
Great, thank you. We'll come back to the back of the room with the lady in the back, please.
My name is Elizabeth Ndakideme. I work with FHI 360 in Tanzania. And the challenge to scale mHealth projects is most of mHealth projects are donor funded. So even if the project works, after the funding is over, then there's no means of getting that project running unless we get another donor. And the Ministry of Health, even if they support the projects, it's very hard for them to get the project moving because of financial issues. Another challenge is getting the telecom companies to give the to reduce the SMS cost because most of the organizations are going solo. So every project is approaching telecom companies to ask for reduction on the SMS costs. It will be maybe possible if, as organizations, we go as a group and maybe have one short code so that they can know what do they reduce the cost of.
Excellent, thank you. Now the gentleman
Yes,
in front.
my name is Eugene. I'm sure by now.
We all know you.
Yeah, in Nigeria, we've deployed over 8,000 midwives and community health workers in primary health care facilities around the country. The family health care facilities are all linked to a secondary care facility for referrals. So there are mobile devices in the primary health care facilities that are used by the community health workers and the midwives for data reporting and sharing. That is one. Then the mobile devices are also used for calling for referrals when the referral issues arise from the primary health care facilities. So the mobile devices are mainly being used between the community health workers and the secondary care facilities and not by the mothers or the public for now. The challenge there is that there's no adequate backup for ambulatory service when the community health workers call the secondary care facilities. That is one. Then secondly, there's, these are simple JavaScript application, low-end phones. So there's no provision for assisted expert support when the community health worker calls the secondary care facility and say, look, I have a situation here. What do I do? Unlike if it were maybe a much more better device, maybe they will get, in case of this, do this. In case of this, do that. In case of this, do that. Because these are, like as it's been said, phones have not yet started delivering babies. Then, the bigger problem is that the private sector in Nigeria, the private providers have not yet thought it appropriate to partner with government in Nigeria for providing mHealth, and we are appealing. We saw MTN Foundation here yesterday, and I started putting it to them. We're holding discussions with a whole lot of people. I think Nigeria is a fertile business ground for the private sector to work with.
I think that's 3 challenges now, too. We had said no more challenges, so can I take you on the next question? Or is it so burning? Can you do 1 second?
I just wanted to answer a question. The lady in the red, I'm sorry.
Daphne.
You mentioned something. I'm here because I'm part of the mHealth roadmap. And so a lot of us volunteered, and we got together to build where we think we're going. What we need is the international community or group or community to come in and tell us, to help us. And I'm here to help, to bring you in. Tell us what you need. You're ahead of us in so many ways, and I'm talking about the international committee. Join us, send me an email, talk to me, and Dr. Arafali is actually the chair, and him and I are trying to bring in the international committee to bring in, and Viva Argentina.
Okay, great. We'll hear from Mark in terms of what he thinks is the key challenge, and then all of you start thinking about which challenge you want to talk about, because I'm going to ask you then to talk in your groups about what would be the key solution. So pick the challenge that you think is most critical of all those that you've heard, and then now all of you are going to solve it, right, in 5 minutes. We'll get the best of your brains working on solutions. So first let's hear from Mark in terms of the key challenge that you think we should be addressing.
Egos. And so, as I said, the key to impact is going to be working across platforms, working across programs, working across donors, working across countries. What's happening now, somebody mentioned donors. The problem isn't the donors. The problem is what they do. It's that what they do is they fund their pet project in their district in a country, and in the next district there's another project that's completely different. Nobody wants to bury their own ego in the interest of a shared solution. It's not just donors, it's phone companies, it's all of us. And the challenge is, this is an area where collaboration really does have a huge payoff, and where if we each try to rule our sandbox, we're not going to get anywhere.
Great. So we'll go back to the sandbox. So pick in your buzz groups, pick the key challenge, and then what's your solution? And we'll take a few of those. But we're going to stay really tight to time. So when we call next time and Mark does his whistle, we need you to just come back to us quickly, okay? So back to your groups. So this is a very interactive panel. It takes all of them to get your attention. Oh, but you were much better behaved that time. Thank you very much. we're really dying to hear your solutions, but I was very gracious to the last folks standing at the mic because many of you gave us 2, 3, 4, this time 1. If you give us more than one solution, the room's going to, what are we going to do, room? Like we'll start clapping or something, right? So that the person has to sit down. Because we have very little time, I want to make sure that everybody gets to their next session and gets to network in the hall. So we'll take the one solution from David Allward in the back. Good to see you. Go ahead.
Great to see you all. We had an interesting discussion really based on the work the Clinton group is doing in Tanzania, which is, it has 2 parts to the one solution, which is map everything that's going on, and 2, say our mission is to create an ecosystem. So everybody needs to participate in the ecosystem because scaling individual things will not work. So building an ecosystem, and then the people who don't want to play don't get invited anymore.
Great. Excellent. To the front. David. I think it's another David,
There's
isn't it?
no way this is one.
Well, we're gonna
so
have
if you're
you
trying
sit
to
down.
fund an mHealth project, you're trying to fund the wrong thing, because most mHealth projects don't generate income. In order to fund mHealth projects and pay community health workers and pay for technology and pay, you need to focus on funding economic development for women. You need to bring social enterprise models to the table that give the women who have time to do this now because they just got water, they just got sanitation, they actually have, they're poised to do something interesting. Those social enterprise models give them a way to generate income by doing something interesting that can then flow into funding and positioning the community for a scalable set of solutions that won't be funded by donors. They'll be funded by a new group of players which include donors, but they also include corporations and governments and multilaterals and kind of, you know, imagine Child Fund or World Vision being able to tap into a system where they can pay a specific set of community health worker activities around a specific solution directly from their donors through M-Pesa, using the switchboard system to identify the opportunities to pay.
Great. Okay. Economic development and the social enterprise systems in the back, please.
Hi, Alice Liu, a consultant for JPIGO, and it sort of ties a little bit into what David Aylward was saying, is that I think some kind of efforts to work with public health officials, the policymakers, to really educate them about the use of information, data, and technology in a systemic and strategic way to manage the delivery of health care. And I think most organizations work in a top-down hierarchical way, and if the vision is coming from the top, I think that's more likely, you're more likely to see people follow. And I think that we've seen a few examples like this in, for instance, in Rwanda. I think that will cut through a lot of the, the resistance. Maybe that will help address issues like paying community health workers. So I think that we need to start at some fundamental level there in empowering and providing the capabilities and knowledge at the top levels and bringing it all the way down to the community health workers.
Good. So if governments at a national level played more of a coordination role across that ecosystem and really developed the policy framework, that could really get everybody to work together and to do sort of the solution perhaps that David had suggested around mapping and creating that ecosystem, but doing that at a national level. Great solutions. I think we're out of time, but I want to hear from, maybe just to let the panelists give one concluding remark. They can either come up with a solution or maybe go back to something that was a key theme for them in their presentation. But thanks to all of you for your engagement. I hope that we kept you all awake. And maybe next year for our maternal and newborn health session, we'll have a partnering session where we can talk about sort of a speed dating format where we can really work on that partnering together to better leverage the strengths of everybody in this room. So we'll take some ideas back to the organizers and come up and see any of us at the table with any of the solutions that you didn't have a chance to share. And thanks for your active engagement. So now, to Paula and then Daphne and Mark. Just quick statements as we conclude.
Thank you for the invitation. It was great participating on this session, and I learned a lot from everyone. Thank you.
I think the idea of funding women, the economic development of women, will underpin the whole changes we can have in the whole health ecosystem. So I'll vote for that one.
I don't think I have an easy answer. I think that it's got to come from a lot of things. Economic development is one, but I'm impatient, and I think that will take a long time. I think technology can help with some things, like training people in a way when there's turnover, you can actually do it cheaper and better. But I think that I'm not a big believer in magic bullets.
Great. So again, I hope this has helped us to think about the future of how we can use mobile health for maternal and newborn health, and that you've also had a chance to meet some of the folks in the room with a lot of expertise that we weren't able to hear from. So let's give everybody a hand. Thank you.